whether it's TB, whether it's, hookworm, even if you can't make a whole career out of it, you can still make a difference. You can still really enjoy that kind of passion. I know a lot of people in this kind of environment have to publish or perish, but I just want to promote that idea that there's a lot that you can do in public health. There's a lot you can do to inspire your colleagues, the community. You can advocate for the health of kids. So just wanted to bring that forward as an idea. For people who don't work in tuberculosis all the time, you may not recognize that before about the year 1900, 1 in 7 people who had ever lived on this planet died of tuberculosis. And closer to that time, it was up to 1 in 4 people in Europe died of tuberculosis. And while Koch discovered the bacterium in 1882, and we started using treatment in the 1950s, we still have a lot of work to do. Still 1 million people or more on the planet die every year of tuberculosis. And unfortunately, children suffer disproportionately. And there's lots of reasons for that. One thing is that their early symptoms in particular are very nonspecific. So may look like malaria, may look like HIV, may look like any number of things. And how do we diagnose adults with tuberculosis? Well, we ask them to cough up sputum in a cup. Sometimes we can get kids to do that, sometimes we can't. So it's harder to make the diagnosis. And at least early in my career, there was very little worldwide public health attention to pediatric tuberculosis because the vast majority of kids with tuberculosis are not contagious. And so when you're trying to really tackle a huge worldwide epidemic or pandemic, you really want to focus on those people who are contagious. So, lots more problems with pediatrics. Young kids disseminate their disease quickly. They progress quickly. And unfortunately, it remains the case that we estimate that probably half of kids with tuberculosis actually never diagnosed and started on TB treatment. Even worse with multi-drug resistant tuberculosis. So that's why kids have kind of gotten the short shrift. So hopefully you'll be impressed at the progress that's been made and be motivated to be part of it. But if you haven't previously drank the Kool-Aid, or I haven't motivated you so far, maybe you're a reader of nonfiction and you might enjoy reading one of these books. So the first book over there, Mountains Beyond Mountains, is the story of the earlier career of Paul Farmer, who might have been the most amazing person ever. And I love his quote, "The idea that some lives matter less is the root of all that's wrong with the world." I'm on board with that. This book is amazing. You would love it. You would also love a book that was published just last year. And this book really threads 3 different themes. One is the unconscionable discrimination against Blacks. And in this case, the story of these Black nurses who took care of essentially all the patients at the Seaview Sanatorium in New York. Also weaving in the history of tuberculosis at the time, leading up to the period where TB drugs were identified. And then finally, some things we all need to think about, which is evidence-based medicine and implicit bias. So I highly recommend. I have 2 copies of this book. One is on a little bookshelf I have for my nurses, but let me know if you want to borrow it. Now, in true disclosure, I haven't read the one on the right, but this just came out in the last month. And there's a few podcasts, I think, on Instagram. I don't really know what Instagram is, but I hear that this guy's podcast is there, also a New York Times interview. I have heard that. And I think we're kindred spirits, because he says he starts to talk about something and his kids say, "I know, Dad, it's tuberculosis." And I dare say my own kids would say the same thing. So again, Kool-Aid, really read one of these books. And if you hadn't had that Kool-Aid, you will have it. You will be impassioned about being involved in tuberculosis. So I always prepare about 5 times as much material as I can ever talk about. And some of you, I think, online probably have heard me speak before. So you know that's true. In fact, you're laughing out loud as I say it. So I'm going to kind of go over the things I wanted to talk about here in terms of the progress of the advances in pediatric tuberculosis during the 30 years of my career, so that, maybe you could take a nap, or if I don't get through all my slides, you'll be okay. So the first thing that I just want to mention, and I'm not going to talk much about it at all, is immune testing. So when I was maybe a medical student, the test that we used is called the Tyne test. It's a crazy little thing where there are 4 little prongs, and they literally had just dipped those prongs into fluid that's called purified protein derivative, PPD. And however much dried onto those prongs, that's how much were put under the skin of the person you wanted to test for tuberculosis. It wasn't very standardized, just a gamish of TB proteins. And from there, people started using the MAN2 test, which is you put a specified amount of the purified protein derivative under the skin. That's what we call the tuberculin skin test. Some people call it PPD. TB doctors like to be really snooty, and we look down our noses at people who still say, place a PPD. No, we place a tuberculin skin test. So I think most of you probably know that we've largely transitioned away from the tuberculin skin tests, and we really like these blood tests, the interferon gamma release assays, because they do not cross-react with most non-tuberculous mycobacteria or the BCG bovis, the bovis that's used in the vaccine. So that's a advancement, but the big advancement is that really just in the last couple of years, the American Academy of Pediatrics has endorsed the use of the IGRA blood test down to any age, recognizing that both tests, the tuberculin skin test and the blood test, the IGRA tests, both have limited sensitivity and good specificity. And again, I'm not going to talk much about this, but I think there's excitement in that these very specific TB proteins that are used in the IGRA blood tests are now being studied in use in a skin test. And I actually like the skin test. Now, they're not easy to place. I always tell people, even I don't get the right intradermal placement sometime, but there's promising data. And in fact, our good friend Dick Brostrom, who's been trying to eliminate tuberculosis in the Pacific Islands, used those new specific skin tests very successfully in one of the recent projects in the Pacific Islands. So that's a big deal. That's a lot of advancement. But please know that these tests can become negative when a child or an adult has TB disease, because their immune system changes and may not react to that. So that's why I talk about the sensitivity of the test. Those negative tests do not rule out TB disease. And by the way, I want to say probably on every slide, I could say, oh, and David's working on this, and David's working on this. So I'm not going to do that. So just suffice it to say that you have quite an expert here in the audience and at your institution. All right, next thing I'm going to tell you a little bit more about is the diagnosis of pediatric tuberculosis. There's lots of new tests, and unfortunately, there is no perfect test. There is no gold standard. So when we're making the diagnosis of pediatric tuberculosis, it is an art. You're looking at the child, you're looking at an x-ray, you're looking at the context of the people they've been exposed to, you're looking at some lab results, and you're asking your friends. We all do it. We all show each other x-rays, we tell each other stories, and we say, is this compelling for diagnosis of tuberculosis? The next thing is treatment of tuberculosis. When I started in the field, there were a lot of people who were uncomfortable using one of the common first 4-line drugs. A lot of people didn't use ethambutol for treatment of children. We're now comfortable using ethambutol. But the exciting thing is there are new drugs and new studies, finally, head-to-head studies or placebo-controlled studies showing how to treat both children with TB disease and latent TB infection. And then lots of public health interventions have progressed. So again, when I started my career, kids every single year going into school would be tested for TB. And when you test 1 million children, 990,000 of whom have no risk for exposure to tuberculosis, you're going to get a whole lot of false positive tests, right? That pre-test probability. And so a big transition has been to what we call targeted screening, targeted testing. And so now, for example, just this last year, a group of us for the California TB Controllers Association changed the guidance, and we're no longer even excluding kids from school who haven't had the screening. So we're only screening kids by risk assessment, by questionnaire. Only if they have a positive questionnaire on the first time they have that risk do we test them. And we're not even keeping them out of school while their parents try to get all that done. So a lot of progress in the appropriate screening of kids for tuberculosis. Genotyping is a way that we try to identify who may have transmitted to whom and what that looks like in your community. A lot of great progress there. And for those of you who take care of adults with tuberculosis, you may know that adults obviously can be contagious with tuberculosis, but not all of them. A lot of people who have TB are actually not contagious. And we have been over isolating a lot of people. So there's new national guidelines as of last spring. And how does that affect children who are very seldom contagious with tuberculosis? Well, it affects them because you could imagine if your family member is holed up in a hospital or some other place where they're isolated from you, they can't earn an income, they can't read you a bedtime story. It's nightmarish. So again, just a little prelude into some of the things that I wanted to teach you about a little bit of here. And on the global stage, again, I told you already that really very little attention paid to pediatric tuberculosis on the global stage 30 years ago. There was a scattered group of clinicians and public health people throughout the world. And now it is amazing how different it is. It is absolutely fabulous. And I mentioned, I have a little graphic here of the logo of the Sentinel Project. If that's not something you're aware of, look at their field guide. It's a fabulous resource. So, you know, again, back in the day, WHO used really subtherapeutic dosing. I should be careful what I say, but dosing for pediatric drugs was quite low back in those days internationally. A lot of research has been done for PK in kids, which is great now. Now, believe it or not, WHO even endorses contact tracing. So if an adult is found with tuberculosis, they recommend testing kids, treating kids with preventive medicine. You know, mind blow transition in 30 years, really just fabulous. And kids have benefited. So you'll see a reference there on the bottom. I tried to reference most things on the slides here, but it's estimated that cases in kids from 1990 to 2023 went down from 2.2 million to 1.3 million, and that children enjoyed the highest declines in cases of all ages. So really, really promising that these things are paying off. All right, again, when I was thinking about preparing this talk, I thought, how can I think about every way that care is different over the last 30 years? And then I looked at my bookshelf. So those of you who know pediatric infectious disease or pediatrics at all, you know about the Red Book. It's the report of the Committee of the Infectious Diseases of the American Academy of Pediatrics. And I have books back from when I was second year resident until now. I had a boss one time, she wasn't ID, you know, just my head of pediatrics, and she saw the books. She says, "Why do you keep those things?" Can you imagine throwing them away? My precious. Anyway, I didn't open each book and see how the chapter changed because Jeff Stark essentially wrote all those chapters anyway. All right, so a little bit about San Francisco, I think the place that a lot of you practice. Again, back in the day when I was at Oakland Children's, one time I was giving this talk at CTCA, not this talk, a different talk, and I was talking about what was going on in Alameda and Contra Costa County, and there was a ton of pediatric tuberculosis, which is why I know a little something about it now. And I gave this talk, and a guy named Dan Chin stood up at the end of the talk, and he said, "Well, Ann, I think what I'm hearing is that we have a completely different epidemic over in San Francisco on that side of the bay than you have over on this side of the bay." And honestly, I didn't even know that. But they had essentially no pediatric TB in San Francisco. So most of the cases were in Chinatown and the Tenderloin, and they were people who didn't tend to have close association with children, or they had different you know, behaviors, whether it's cough hygiene, whether it's who lives in the household, whatever. They had very, very few cases in San Francisco. And when I reached out to Janice Louie, who is your medical director of your TB clinic here at the General, or I guess now we have to include Zuckerberg in there. I'm gonna say the General. You know, she said in the 8 years that she's been doing this, they have 0 to 1 pediatric cases of TB each year. Now, some of you may be thinking, I feel like we see more than that at our children's hospital. Well, think about the fact that a lot of your children here actually don't live in San Francisco County, right? You're a huge tertiary resource, and we appreciate that. But something, she said for the 8 years, 0 to 1 cases each year. And now you can see on the slide right now, these are the pediatric cases of children who live in San Francisco County. So a 17-year-old recently came from Philippines and screened because of an abnormal x-ray, a kid who came in for symptoms into urgent care. And as that was played out, found out that the mom had extensive cavitary disease. a 5-year-old, a 3-year-old, and this isn't all one group of kids. These are kids from different places in the world, different family groups. And whenever that's going on, you have to be a little bit worried that you're having recent transmission. In pediatrics, we call it a sentinel event. This is a concern about the pattern and your situation. So the good news is you have an amazing team here. You're a great resource to them, but in the public health department, they sort of know what to do. And they were already doing a lot of great things. So this information comes from Susanna Graves, who is your TB controller. And I'm not going to read all this. You'll have these slides available later, but they do a lot of great work with maternal child health, with Head Start, with the school district, referencing that new guidance that Susanna was also part of putting that together, your immunization clinic. And I'm super excited about this bullet point. I understand you can get appointments for primary care for patients 1 to 3 days. That is also another mind blow. Let's just suffice it to say, in other parts of the Bay Area, kids cannot get visits that quickly. It's super important, right? In this whole process of the school screening, we're trying to get kids into their primary care. We're trying to get them access to immunizations and all the things that kids need. All kids need more than just TB screening. So that's amazing and good for you. And the phone number is there. We understand that the TB clinic does free screening for people in shelters, including family shelters. And then the last bullet is another passion of mine, TB and pregnancy. And Allie Phillips, the wonderful nurse practitioner there in the TB clinic, has established this protocol with the OB providers. A lot of people are reluctant, for lack of a better word, a stronger word, to take any kind of medicines they don't have to during pregnancy, appropriately so. But pregnancy is a particularly high risk time for TB, and we could talk offline if you like to. It's very important for those people who are not comfortable taking it during pregnancy that they get into care right after pregnancy and get tucked in there. So lots of great things happening in San Francisco County, lots of things that you could get involved with if you're interested. And this is a picture that Susanna sent me about one of their health program coordinators who is doing outreach with a group of promotores, people who go and promote health in the community. And this, to me, this is what has to happen. The communities, we'll talk a little bit about it, but not as much time as it deserves. There's enormous stigma in the TB world. People who come from parts of the world where there's a lot of TB, there's a lot of deaths. They feel like it's associated with poverty, with poor hygiene, with lack of education. Well, I'm here to tell you that anyone who looks like anything can get tuberculosis. And the reason that it's associated with poverty and lack of access to care is because that's where, unfortunately, people have the most stigma. So if we can help community groups have confidence and teach each other that it's okay to be open to TB testing, to TB treatment, to protecting your children, we will be a lot better off. I think that's what it's going to take, community by community. And this is what I'll call an old-fashioned contact investigation. So I'm briefly alluded to genotyping, which has made a nice difference. But this is the contact investigation. This is actually a source case investigation. So a contact investigation means you start with an adolescent or adult who is likely to be contagious with tuberculosis, and you test their contacts. In this case, what you can see, let me see if this pointer works. Can you see the pointer? No, I can't see the pointer. Up on the top right, it says confirmed TB case. That's a child. So when the child is the first case, then we want to test as many people around them as we can to see who else might be infected, who else might have had disease, and who might have given it to that child. So that's called a source case investigation. And in this very, very recent active situation, the county of state and the city and county of San Francisco TB program was able to test 13 contacts. They found the source case, the red writing below the original child, quantiferon positive, chest x-ray abnormal, smear positive. Smear positive means there's lots of germs in the sputum. And of all the people, there's one little correction to this slide. out of 11 people they tested, 10 were positive. So remember what I told you, that not everybody is very contagious with tuberculosis? We like to say that 20% of people transmit to 80% of the people who will eventually become infected. So there's lots of people who are not much contagious, but a situation like this, what do we start calling this in COVID? Super spreader. So this person was very contagious. And when we do this kind of traditional hard public health work, this is one way that we protect children and we protect the community and we promote everybody's health. And this is the other thing I wanted to just very briefly mention, and that's this phenomenon of genotyping. So this goes to some of the ways that people are promoting health and doing more novel activities to decrease pediatric and adult tuberculosis. So the top paper there is very original study, was published by Peter Small, who went on to become the head of Gates Foundation TB work. And then everybody else there is just a who's who of royalty in TB at that time, and much beloved friends and colleagues. And then we were involved, and honestly, this next study, that paper just won down. That's why I started being very methodical about testing kids for TB. So collecting the specimens that have the highest yield for growing the TB germ. And we wound up finding really interesting information. We wound up finding that there is a good handful of kids who were not actually infected by the person we thought they were infected by. And they found this phenomenon to be true in other parts of the world when there's a lot of tuberculosis. So at that time in Oakland, there was a lot of pediatric tuberculosis. There was a lot of adult tuberculosis. Kids were getting care from auntie and from grandparents and from babysitters. And what we found is their source case that we thought. I had a case one time where the little baby, the mom had pan-susceptible tuberculosis and the baby had isoniazid resistant. The baby didn't get the disease from the mom, she got it from her grandpa. And this is important to know if you want to protect kids and really promote public health. And that now is even way more fancy. So back in those days, we used these specific probes. Now they sequence the whole genome of every culture grown in this country of someone with tuberculosis. It goes to a regional lab, and there's a very fancy software program that compares these isolates to see not only if one person was the source to another, but how they were connected and how recently someone was infected. It's crazy fancy. But I already alluded to the fact that it's hard to get those cultures from kids, right? They don't hawk up those specimens. And so in pediatric tuberculosis, the CDC and your state program here, CDPH, TB Control Branch, is working on a project that's on the bottom here, which is the National Genotype Independent Alerting System. So they're looking at 3 different parameters and letting jurisdictions know if they're seeing more pediatric TB than an average, more pediatric TB than they used to, or if they suddenly see a change. So I dare say San Francisco is going to be getting a call from these people, but these are the ways that we have to attack it if we really wanted to protect kids. So this is the kind of progress that we need. Okay, I'm gonna take a breath here. How am I doing for time? Am I almost done? All right, I have about 500 more slides. Don't worry, you leave when you have to. All right, I don't have a pointer, so you're just gonna kind of have to track this. This is a slide showing the number of TB cases altogether, all ages, from 1953 to 2017. So you'll see there was a dramatic decline in the 50s, 60s, 70s, 80s. And that 53 was when they started the surveillance, the modern surveillance for tuberculosis in the United States. So saw a really nice decline. The green line is the incidence or the case rates. But you see what happened in that kind of early 80s before my career started, the big blue arrow as Anne's career started. What happened is public health funding went to hell in a handbasket. They said, oh, you don't have to give it to tuberculosis, give it to whoever you want. We unfortunately had the HIV epidemic. We had a lot of people who were in hospitals without effective infection control. And then we had a change in immigration. So you see what happened in the context of this big picture. It looks like that resurgence, we called it, in the late 80s, peaking in that early 90s. It looks small on this picture, but back then it was a showstopper. It was panic mode. And honestly, it was a really wonderful time to make amazing relationships with colleagues and families and community and do the right thing. But I'm going to take credit for all the rest of the decline. How do you like that? Right? Okay. So you can see on the right-hand side some of the other exciting things that happened in tuberculosis, because people got excited about making a difference and doing this kind of work again. All right, you kind of had an idea what happened down to 2017, but what's happened more recently? What's happened more recently is that we continue to have a very slow, steady decline until COVID. All right, so what happened during COVID? Did people stop having tuberculosis? No. 83% of people in California in particular who have active tuberculosis, mostly those adults, right? They've been harboring it in their lungs, what we call latent, for decades. Did that stop activating? No. We stopped diagnosing it. And I dare say a good number of those people died while they had tuberculosis and they had COVID, but we didn't make that diagnosis. So it looks like we were doing something great and our numbers plummeted in 2020. But they've crept back up, and in the United States as a whole, actually, our numbers are up past where we would have expected them to be had we continued the nice decline. So stuff is going on, and there's a lot of work to be done. And in San Francisco, they had the same decline in 2020, and now they've seen the same increase. Knock on wood. This is actual wood, by the way. This is wood right here. I usually knock on my head. Their numbers went up quite a bit in 2023 and 2024, 60% increase from 2022 to 2024. I don't know if anyone else has had that, but that we could talk about at a different time. So the good news is San Francisco has not surpassed their pre-pandemic numbers, and that's good. And your team is working very, very hard to address that. And I'm not just saying that because they're my buddies. They really have a world-class TB program, but there's a lot to do. Let me just also say before I move on, that on the left-hand bar graph that shows the United States as a whole, the dark purplish blue is people born outside the United States, and then the top kind of lavender is people born inside the United States. And so, we see that a very disproportionate number of people with tuberculosis are born outside the United States, and that percentage is increasing over time. It's even more dramatic in places like San Francisco, Santa Clara County. In Santa Clara County, between 95 and 97% of our cases were born outside the United States. Those are our neighbors. That's our community. That's our mission. That's where we need to do our best work. All right, so I'm going to talk about pediatrics here. This graph, so this is a CDC PEDS TB slide deck that Mark Lobato made, I want to say, in about like 2013, and then it got updated in 2017. I don't know if anyone noticed, but a bit ago, before the administration changed, the CDC updated their website, and now stuff that I used to know where it is hard to find. But if you want this slide deck, just email me and I'll send it to you, because there's a lot of great ways to look at and think about PEDS TB. But what you can see is in '93, again, close to the time that I started my career, there was a lot more PEDS TB than there is now. So that's great news. And the very bottom, that blue, is the youngest children, less than 1 year of age. Remember, if you're less than 1 year of age and you breathe in that tuberculosis germ, you have a 40% chance of the germ progressing rapidly to develop TB disease. And that's compared to people, well, I'm old now, but let's say David's age. If he breathed it in, he would control it, only 5 to 10% chance that it would wake up. Littlest kids are at the highest risk for TB disease. Now, the green band here is the 0 to 4 year olds or 1 to 4 year olds, and they've had the most decline. Kids up until 4 still have a higher risk than the average population of getting TB disease. And then you can see maybe on the top right, you can see what's been happening in 23 and 24. 16% increase In kids 0 to 4, 9% increase, 5 to 14, 11%, 15 to 14, 16, 25 to 44. So remember what I told you? Those older folks have been harboring the germ for all these years. In Santa Clara County, about half of our patients are over 65. These numbers increasing in these last 2 years is a really concerning thing for the whole country, that we're starting to see more recent transmission, which means a change in a pattern of well-controlled public health TB control going in the right direction, and concerning pattern that we have a lot more work to do. We've done the work before, we can do the work again. Unfortunately, we do need cash and people. Smiling. All right, so I alluded to the fact that David told me that people have mentioned that I've taken care of interesting patients that had a lot to share with us. And so this is literally the first patient I ever took care of in my career. And this was my first year out of fellowship. I trained in Pittsburgh, Pennsylvania, where we didn't have a lot of recent immigrants, right? Our immigrants were a few generations old. And so I took care of no tuberculosis in my fellowship. And I came to California, and this is my first patient. So I don't know if you can see the patchy airspace disease. This was before there were digital x-rays. I literally had my husband's camera, which then was printed on film. Like, I know you guys, like, that's blowing your mind. But this kid has patchy airspace disease. And I should say the kid, this is a 2-day-old baby. So this baby developed fever on their second day of life. Over the course of time, this, in the week of life, when I was trying to figure out what they had, lymph node swelling, liver and spleen enlargement, breathing fast, fever, turned out to be congenital tuberculosis. The mother had ingested something which was unpasteurized, and she had gotten Mycobacterium bovis from that, and she had her primary infection. When moms have their primary infection, they can, the organism can rarely pass across the placenta to the baby, rarely. So the reason I'm showing you this story is because this situation led me to really all of my passion in tuberculosis and a lot of the work I did. So I didn't even know how to begin to make a diagnosis of tuberculosis in that child. You know who actually basically told me what it was going to be? The adult ID fellow. I sent the mom in because I knew she had meningitis, because when she came to the nursery, she was too unwell to come to the nursery at phone. I was talking to her on the phone. I was trying to make the diagnosis of the mom over the phone. And when she came into the nursery finally in person, she held her head as she sat down. So I knew she had meningitis. And when I called the adult ID fellow to evaluate her, he said, oh, she has TB meningitis. I'm like, oh, she has no cough. Like, I didn't know that was a thing, but it's a big thing. Okay. Not everybody has cough. The point of the story is I didn't know how to collect a specimen to prove that this was tuberculosis. And I learned that, of course, a 2-day-old baby can't hawk up sputum into a cup, but what do? What do we all do? Swallow our mucus, and you can put a little tube down into their stomach. Again, didn't even know how to do it. So I figured it out over time, and then I wanted to share with the world how to do it. And so that's what I looked like when I was younger. I think I still have the same pearls on, but I have brown hair. And I taught the world that you do 3 gastric aspirates first thing in the morning before the child has anything to eat or drink. And the star was Nicholas Loeffler. Do you guys know my last name? Loeffler. So those are Lauren Poole's hands. Nowadays, after doing so much infection control work, I would never have someone do any procedure without gloves on, but I'm so embarrassed about that. I do want to point out my Curry team is here. Kay Wallace really has been the project manager for everything I've ever done in Curry. That's been a great thing. So grateful. But we developed this video, which I brought with me, by the way. Maybe we should have a raffle. I have 2 copies of it. This one is unopened. Check it out. Who has a VHS recorder at their house? David still does. Okay, incoming. Here you go. Anyway, joking aside, people came to joke and tease me and call me the gastric aspirate queen. And I'd go to Peru to teach, and people would come up to me and they said, you're the gastric aspirate lady. So anyway, Nicholas has he gave a specific approval this week to keep showing the picture and mention his name. But maybe you didn't know that that's a younger version of my husband who says he's watching online. And then this is Nicholas. The top picture of Nicholas is his first day at college. And this one is this Christmas. And so you can see this video still, it's still very pertinent. There are some things that are different. We could talk offline about that, but you can find it on the Curry website. You can also find it on YouTube. On YouTube, they stopped counting 10 years ago. 10 years ago, they had 127,000 hits or views, right? So we're proud of that. And, you know, yeah. So, okay, more of me taking credit. Check this out. So when I started my career, not even half of children who were diagnosed with tuberculosis even had cultures collected. 22% were culture positive. And now, this is in 2017, 34% are positive, and a lot more people are trying to collect specimens. Now, I will say it's not just gastric aspirates, and I'll show you more of that. How am I doing for time?
12:40.
It's 12:40, yeah, right. 12:41. Okay, well, we're staying till 3, right? All right. So I knew this would happen, but I feel like I've already shared a lot of information. This, you can look at this slide later, but I just did want to point out that the youngest kids, babies, have a high yield. My personal track record is if I have a kid who's less than 6 months of age and I know they have tuberculosis because they just have the classic, I have 100% yield on when I do the gastric aspirate. So youngest babies, teenagers are most likely, but it's worth trying. So in addition to the gastric aspirates, which I'm still a believer in for little kids, if you get a kid who's like 2 or 3 years old and they have no symptoms and all they have is a swollen lymph node in their chest, we call that TB. It is TB. If we don't treat that, a good chunk of those kids will progress on and 25% will die. But those gastric aspirates are not going to have a high yield. So I did want to point out that there's a lot of places in the world where induced sputum works for them. There's clinics in our country that induced sputum works for them. I start sputum induction maybe around age 5, but there is a protocol. Heather Czar developed this where they give kids saline, they promote their cough, and if they're little, they put a suction catheter into the back of their throat and aspirate the sputum that they're hawking up. I personally prefer gastrics because I think my numbers are better. And in addition, what people do before this is sputum induction, oftentimes they give 5 or 10 minutes of albuterol. I got my gastric aspirates done in less than 5 minutes. So that's just my interpretation of the data. But you have to do what works for your staff, your yield, and your patients. Nasopharyngeal aspirates, where you just suction the back of the nose, unfortunately, those are not as good yield, but there's lots of other exciting things happening. So stool, again, not as good a yield as a high quality sputum induction or a gastric aspirate, but if you combine a nasopharyngeal specimen and a stool or do multiples, you can get to a yield that's appealing and maybe more tolerated by families in particular. So having said that, what we like to say is in general, maybe only about 40% yield of 3 gastric aspirates, kind of across all comers of those less than 5-year-olds who you would do that for. So why do we do it? Well, it can confirm the disease. You can, if it's positive for a nucleic acid amplification test, especially one that has RPOB mutation detection, like the Expert MTB RIF, you're going to get that result in like a day. So that's huge. And then we can do genotyping, which really helps us understand the transmission pattern. And then, of course, all the phenotypic and genotypic susceptibility testing we do now currently is done on culture isolates. So we need that if we want to get all those results. But the important thing is people have to make sure that you understand it doesn't rule out TB, because a good number of kids are still going to have negatives. Unlike adults, 80% of adults have a positive culture. All right, I think I've mentioned it that kids have paucibacillary disease. They have lower number of organisms. A lot of what you see on their chest imaging is immune. It's not like eating your chest, your parenchyma, and getting a cavity with billions and billions of organisms like adults. So that's why their culture yields are low. And this is a little of the data about the use of this the expert MTB riff on pediatric specimens. So again, back in the day, we wouldn't have had any of this, but now, fortunately, people are doing these studies in pediatrics. And what we're finding is, we were hoping when they first licensed those tests, all they're looking for is a little bit of the DNA. We thought, surely this has to be a higher yield than culture, but it's not. It's 73% sensitive for gastric aspirates. It does have high yield. Stool, which is easier to collect than putting a tube down in somebody's nose. Stool, unfortunately, is 61%, but it's helpful if it's positive because it's rapid, it's non-invasive, and you get those susceptibility results. Initially, we're super excited about this new generation of tests, the Expert MTB Riff Ultra. We were excited because it looked better in adult disease, even smear negative disease, but it turns out it hasn't been better in the pediatrics sampling. But super excited that people are doing these studies now when once upon a time they were not. And here's the biggest concern about Ultra. The biggest concern is that the company, Cepheid, if any of you are stockholders and can go to their meetings, it's in Sunnyvale, they are not going through the FDA licensure process, right? So it's not available in the United States. Well, what happens if they say, yeah, we're going to put all our chips in the Ultra and we're not going to support the regular Expert MTB Riff, which is what is licensed in the United States. So that would be bad. If you have any way to advocate for that. So there's lots of new tests. Again, David is involved in some of these things, so I'm not going to go there. But what we really, really need is testing that tells the difference between a kid who has an infection versus disease. And some of these things like the RNA expression and the biomarkers have the hope to do that. So that's really what we need here in the future. So I'm going to show you a couple of pictures. 10-year-old Ethiopian adoptee. Long story how this played out, but the short version, I got a call from a pediatrician. I said, well, start with chest x-ray today, high quality sputum, let's talk. Unfortunately, that didn't happen, and it was months before this x-ray was taken. So for those of you who read x-rays, that's bad. That's bad. And she was known to have had a seizure, and she's got a big old tuberculoma in her brain. Here's another child. This is a 9-month-old or 8-month-old. That's when I first met her. So her frontal view is not the world's best inspiration, but I don't see anything too exciting. But when you look at her lateral view, you see that potato in her hilum. That is the classic appearance of the lymphadenopathy that's classic for pediatric tuberculosis. So she was screened as an adoptee. Her adoptive parents, which in my family we call the parents, she had her TST screening and that was positive. She had the x-ray. The parents didn't know anything about TB or serial respiratory illnesses, but she was thriving. She had been a little scrawny little thing. I have a very cute picture of her in the orphanage. She was scrawny. She came to Portland. She was eating like a little piggy and looked great. And then finally, this is a 15-year-old boy, had just come from Vietnam, had just been in Portland for 2 months and went to the ER because he had hip pain. And the rheumatologist, who's a good friend of mine, said, okay, well, he clearly has an autoimmune disease, and let's get a quantiferon, which is the interferon gamma release assay, looking for tuberculosis, and let's give him a slug of steroids. Well, she said, let's give him a slug of steroids a few days later, but unfortunately hadn't looked at the quantiferon. So this is what his x-ray looked like back then. Again, without a pointer, it's going to be hard, but I'm going to blow it up here on the next slide and show you up in the top right that when he had his x-ray, before he got his steroids, he had a little bit of junkiness, little tiny bit in the left upper lobe. We call that fibronodular, and a lot of times that's scarring or old inactive TB. But in the audience here, I need your help. I'm getting tired. What happens when you give steroids to someone who has untreated tuberculosis or chicken pox or fungal infection? David is saying bad things happen, bad things that you don't want to have happen. The immune system is suppressed and the germ is happy to not be suppressed. And now you can see that everything got worse. So what do you think those 3 kids had in common? They all had multi-drug resistant tuberculosis. And I'm glad and blessed that I cultured their specimens aggressively. The kid with the hip, I actually needed to biopsy his hip because by then we didn't know if he had an autoimmune disease or if this is all tuberculosis. If he had an autoimmune disease, which he turned out to have, juvenile idiopathic arthritis, a spondylosis form, he needed immunosuppression. He wound up needing his hip replaced anyway. I have a very cute picture of my husband and his dad putting together an exercise bike so he could get into condition to get his hip replaced. So multi-drug resistant tuberculosis means the germ is resistant to isoniazid and rifampin. And until just a couple of years ago, this would have taken 18, 24 months to cure. It actually took me 3 years to cure that guy. He threw up everything. Let's just say that was a bad scene. That's the only kid I've ever had to put a G-tube in to get his treatment in. And his parents would have to set their alarm. They'd have to get up at 2 a.m, give his TB meds, and then run formula the rest of the night. He was 15. He's now in college, by the way. And sometimes one of my Vietnamese nurses in Portland would run into him. He's thriving. I went to his house a few times to do house calls and whatnot. And I always told him, we'll never give up on you. And we didn't. But the good news and the reason I'm telling the story is that the fact that in my early career, we really didn't have a ton of evidence about how to treat multi-drug resistant tuberculosis, but there was a lot of experience emerging. And so Jenny Flood, who I hope is on the call, she's your head of TB for the state of California. She and I met at the park at the zoo one day, the Oakland Zoo, with our kids, and we sketched on a napkin the chapters of this book that Kay Wallace made happen. I said Kay and I made the book happen, but really it was Kay Wallace. I just was editor. But so there's 4 editions and then some translations of the book. But this is also my bookshelf. I saw this after I took the picture of the red book. See, there's a book there that says A Clinician's Guide to Tuberculosis. A very famous TB guy named Mike Eisman wrote that book. And so Chuck Daly actually suggested that we steal that name. And that's how we have the name of the book. So if that's not a book and you ever need to know about tuberculosis, I no longer am the editor, so now I can brag. But there's a lot about drug susceptible. There's a lot in that book that we think is really helpful and is the goal of my career. So I'm going to stop pretty much, but just show you this big bad X-ray of this little girl who's exposed to her grandfather. Unfortunately, her grandfather was treated with rifampin monotherapy, and even though he had a cavity and 5 months of cough. So remember that TB is treated with 4 drugs after culture collection. He didn't have any of those things done. He got 1 drug. And by the time he was identified, he had rifampin resistance. So that's a pain in the bahoonie to treat, and you don't want to do it. But now we have data. We have data for treatment of multi-drug resistant tuberculosis, even in children, real studies, head-to-head. Could not be more excited. So when you get the slide deck here that you can see, you can get by reaching out to me or Marcella, but there's lots of resources. This is in the drug resistant guide. And May 30th, you're going to see on the Curry website a complete update, thanks to Mari, of the audio, the webinar that will give you all the basics about tuberculosis that I didn't have time to talk about today, and all the resources that we've developed and now updated over the years. So I'm going to have to stop there. If you can still see the slide, you can read about the exciting news that there's good evidence that for non-severe pediatric tuberculosis, 4 months of treatment has good evidence to be effective. I see a question here in the audience, and I'll repeat it.
So I was thinking about the gastric aspirates. Do you have any change in sensitivity on acid suppression or off of acid suppression for culture recovery?
Yeah, that's a great question. I don't know that anyone's ever studied that. Do you know if anyone's, oh, sorry, the question was acid suppression. Do you know if anyone's ever studied it?
No, but often when we get the gastric aspirate, when we process it, do things.
Yeah, so I actually, one of my mentors when I was back at Oakland Children's a long time ago, someone had suggested that if it's true that the stomach acid deactivates some of the TB germs, because if you think about it, everybody swallows their mucus, and not everybody has GI TB. So the bugs must die at some point, right? What if you suppress their acid and then you cultured it? So I always had the idea, maybe you want to take this idea. And so you give like a couple doses of a PPI, you do your gastrics, and then the last time you're going to collect the gastrics, then you put down the TB meds. I have done that before for kids who the family was thinking, oh, this kid's never going to swallow these meds. I'll put them down the NG tube after the last gastric aspirate, but I don't think that's ever been studied, the effect of acid suppression.
We had a couple online. One is Dr. Davis. You have a following for this talk. So Dr. Davis from the Long Beach Department of Health said that Long Beach has also had about a 68% increase recently in TB cases, just like San Francisco. And then Mira Srinivasan.
Hi, Mira.
She says hi. Also, thank you for the great presentation. Was curious your thoughts about diabetes being a factor in the increase in active TB disease among the young adult population. We also saw an increase in TB disease in our 25 to 44-year-old group, and a good amount also have diabetes.
Yeah, something else I haven't studied. In Santa Clara County, about 35% of our TB cases have diabetes, and there's a strong association, not just at our place, but well known with poor control of diabetes is a strong predictor, but I don't know anything about the recent increases. It's sure true that people get suboptimal primary care. The people we see with tuberculosis, they're often not well connected to their primary care. And in fact, it's part of our guidelines that every single person gets a hemoglobin A1C. It's the national guidelines say for at-risk people, we get it for every TB patient. So yeah, it's a really, really important.
So is the treatment more difficult also in the
Yes,
setting of diabetes?
yes. If you don't get their diabetes under control, the TB will stay smear positive. It will stay culture positive. It is very hard to treat if that diabetes is not under control. And I remember we used to see this when I was a hospitalist, patients with diabetes and asthma, diabetes and other infections. If you got the diabetes under control, everything else was easier to control. That might have been an anecdotal observation, but I thought the endocrinologist talked about that too. As you can see, for 20 years, I did the Curry warm line. So the Curry International Tuberculosis Center, we have a warm line process. If you if you go online to citc.idcrowd.org, you can register there and ask TB questions. There's nurse consultants, adult TB consultants, and then pediatric consultants. For 20 years, I did it myself, and I answered 2,000 questions. And it was an enormous source of pride, and I literally loved it. But I came to realize that, I really need for lots of other pediatricians to know a lot about tuberculosis. And so now I'm super lucky and blessed to have 4 partners, including our most recent addition, your Dr. Jagannath.
Also, Kelly Sophie, I might have put in a link here to the 3rd edition book for drug-resistant tuberculosis, a survival guide.
Yeah, so there was the 3rd edition, and then there's a 3rd edition update, which I think was like December of 2022. So look for that update. That's the most recent, but we are working on the 4th edition.
And diabetes under control is important.
And then also, if you want to read a little bit more about health inequities, this is an article I wrote for Santa Clara County Medical Association. So good stuff.
Thank you.
Thank you.
So I just want to extend our thank you, Anne, for coming. And, it's clear why she has a wide following. Literally everyone in the Western region and probably the world knows M Loeffler for really her decades of advocacy and support. So thank you, Anne.
Thank you.
Thanks, everyone. Bye-bye.
I think for lunch.
I want to, I actually have all the books and I read that and everything.
Already, didn't it just come out?
Yeah, I read it.
Oh my God.
It's a good read. It's for people that are really like that everything's TV. It's for people that are like, you know, he clearly nerded out on TV and everything, and so you're just like,
I feel like you fit that.
yes, it's got a cult like thing, but
What I was worried about with the interview is I felt like he didn't,
Thank you for coming.
he didn't emphasize the stigma and the reluctance of so many people to get tested, to be treated with closer contacts, and until we normalize that, it's just an uphill battle. It's not like he's saying, oh, this is not valued and politicians don't value. No, it's bigger than that.
Yeah.
That's what's great about Dick's projects in Marshall and in Shook. They went in months ahead of time. They had parades and they had radio shows and people talking to people. Sorry if you already heard this.
no.
Trying to figure out, sorry, hi, thanks for the talk. You said you would, sorry, who did you say to contact to get the slide?
I mean, do you know Marcella?